Okay. Yeah. So the topic is jaundice. Can somebody
Dr.
tell me the
Krishna
causes of?
is today's our presenter.
Yeah. Is he able to hear me?
Yes, sir, I'm able to hear
Sir,
you, sir.
your voice is low, sir.
Okay. What are the surgical causes of jaundice?
Sir, whether it can be related to stone-related disease, benign or malignant, can
Classified.
be.
Classified.
Yes, sir. It can be classified as two, sir: benign causes and malignant causes. The very broad classification is there in benign diseases, where whether it can be due to stones or strictures in the biliary tree, uh, because of inflammatory process, especially related to chronic pancreatitis or autoimmune diseases, like IgG4 related autoimmune disease. Mm. Or even it can be due to surgical related, sir, post-lap
See,
cholecystectomy.
whenever you give an answer to such a question, the examiner wants you to classify. And benign and malignant is too broad a classification and gives us no indication of what is the cause. Your classification must reflect a valid division. Say, for
Okay.
example, you say it is prehepatic, hepatic, and post-hepatic, and then you qualify that by saying surgical obstructive jaundice is usually either uh, prehepatic or it is post-hepatic. Hepatic causes are less frequently surgical causes. They're more likely to be uh, medical causes of jaundice.
Yes. So, sir, either shall I continue, sir?
Yeah, with the classification I mentioned.
Yes. So we can classify to benign diseases and benign and malignant causes, other intrahepatic causes and extrahepatic causes of obstructive jaundice, surgical jaundice. This intrahepatic causes, sir, if there is any mass lesion causing obstruction into the biliary system, then these cases can have obstructive jaundice. Most of the cases are having extrahepatic causes of obstructive jaundice, various levels, starting from the hilum. It can at the level of gallbladder. It can be due to gallbladder in the CBD, even in the head of the pancreas. Very rarely, because of collateralization of the portal vein, that is also can cause us portal biliopathy, sir. These are the extrahepatic causes.
Okay.
Like, yes, sir.
What about
Other,
choledochal cyst?
yes, sir. Choledochal cyst is also cause, sir. That it is in the CBD. The pathology
Which
lies in the
types of
CBD.
choledochal cysts are extrahepatic?
Type, sir, type 1, type 2, 3, and type 4, sir. Caroli's only is intrahepatic.
It's
No,
purely intrahepatic. Type 4 also is hepatic and extrahepatic.
both will be there. Both will be there
Yeah.
in type 4. Yes, sir.
So, what is the cause for IgG for hepatitis?
Sir, it
What
is
are
an
the
auto.
markers to suspect IgG for hepatitis, either on clinical
और देखो पीछे ही
factors
मना कर
or imaging or whatever?
Clinically, it will be the age of the presentation of the patient. Usually, the patient is young age in IgG4 disease, but it is known that they can present even at a later stage of
पेट
disease
स्कैन नहीं
also.
कराना पड़ेगा पेट स्कैन यहाँ होता है सादोपुर में
Other
Good
than
morning,
that,
sir. Dr. Kapoor has come. He will
Morning.
now take care of the rest.
No, Rajan, carry on, please.
Yeah.
I was little late today. Carry on.
sir, other than that, patient radiologically, sir,
पीजीआई दिखा लेना ना कोई दवाई नहीं देना
I'm not sure about radiological findings, sir, to
सारे फूड पे
differentiate
जाके पीजीआई
IgG4
दिखाओ
related.
There is a capsule around the liver that will enhance in the arterial phase and have a slow washout in the venous phase. Just like pancreas, also, it is sausage. Pancreas becomes sausage shaped, and it is associated with
आपका जो
hepatic causes of IgG for jaundice.
थोड़ा सा अलग केस है आपका उधर दिखाओ
Everyone on the audience, please mute yourself because we are having a little bit of.
पीजीआई दिखाना है हाँ इधर उधर धक्के नहीं खाने जांचें सारी हो गई आपकी गरीब आदमी तो नहीं रात में जाना उधर ही पड़ेगा
Yeah. So, what about the biliary system? Or how is the biliary system affected in IgG4 hepatitis?
They cause a stricture in
Yeah,
the
multiple stricturing.
multiple
It
stricture
can
in
present as sclerosing cholangitis, but then you do IgG4 and you find it is not sclerosing cholangitis. You can test IgG4 in the blood and you can make a diagnosis. And also in a biopsy, you can do IgG4 staining, which will show you
ठीक है
this
रोहित, आपके लिए
diagnosis.
कह रहा हूँ, अच्छा रहेगा, पीछे दिखाओ, धक्के मत
Yes.
खाओ इधर उधर। आज नहीं, सोमवार को जाओ या मंगल को जाओ, ठीक है?
I missed the initial part of discussion, so sorry if I repeat something which has already been covered. But there will be cases both in your clinical practice and in the exam where you have biliary obstruction as evidenced by history, LFT, ultrasound, some cholangiography, and you know that the obstruction is in the biliary system. But it would be very difficult to establish a tissue diagnosis, because getting a tissue diagnosis from a cholangiocarcinoma is one, not easy. You can do a brush at ERCP if it is a lower cholangiocarcinoma. You can do a percutaneous transhepatic brush cytology if for some reason you have to do PTBD. You can do an EUS guided FNAC, but it is not very sensitive. It is specific, but it is not very sensitive because the tissue you get may not be adequate. Most of these cholangiocarcinomas have more fibrous element, desmoplasia, rather than malignant cells. So then the dilemma is whether to treat it as malignancy or benign. The general dictum is, Dr. Jiten, can you please mute yourself? Dr. Jiten? Dr. Jiten Chauhan, please mute yourself.
और इसके
So
अलावा
the dictum is that
अच्छा ठीक है,
unless there is a
और इसके अलावा
clear-cut cause like stone disease, like you have parasites in the biliary tree which are causing obstruction, or you have the classical imaging picture of primary sclerosing cholangitis, you will have to treat it as cholangiocarcinoma. So just as in pancreatic cancer or periampullary cancer, the dictum is that you make every attempt to get a tissue diagnosis, but it is not mandatory. After exhausting all the attempts to get a tissue diagnosis, if you can't still get it, based on radiological suspicion alone, you can go ahead and do the resection. Finally, some of these cases, small number of these cases, will turn out to be benign. And that is how most of these benign entities like groove pancreatitis, autoimmune pancreatitis, IgG4 cholangiopathy, they are diagnosed. They are not diagnosed preoperatively. They are diagnosed only as a finding on histology. So when you are operating on a patient with a negative tissue diagnosis, counseling and consent process is very, very important. You have to inform the patient, and this you have to mention in the exam also, that we have exhausted all attempts to get a tissue diagnosis. We haven't got it. So I can't be 100% sure that it is malignant, but we have a high suspicion of malignancy. And that is why we are going ahead with resection. Don't be surprised if it turns out to be benign. Then don't turn back and say that why did you do the operation when it was not cancer. But if the patient does well, it is a fortunate situation. The only medico-legal issue comes when the final diagnosis comes as benign, and unfortunately there is a mortality or major morbidity. So that is where the counseling and consent, everything documented in writing with signatures, will come to your rescue. So there will be situations where it would be, and same happens in gallbladder. A thick-walled gallbladder may be benign, may be malignant, but that issue we will discuss at some other time. The second thing is, in between, I heard the term that portal biliopathy, which is now called portal cavernomatous cholangiopathy. And there are two entities. One is the classical extrahepatic portal venous obstruction, which is seen in children and adolescents. Of course, these patients may grow into adulthood also, where there is no portal vein seen when you do a imaging like CT angio, MR angio, or Doppler. But the portal vein is replaced by a cavernomatous formation, by a bunch of collaterals. That is what causes portal cavernomatous cholangiopathy, where there is obstruction on the bile duct. On the other hand, in some adults, who have, say, pancreatic or biliary malignancy, or who have chronic inflammation in the biliary tract or in the pancreas, you may have portal vein thrombosis, say because of chronic pancreatitis, say because of recurrent cholangitis. And that portal vein thrombosis then causes portal hypertension. But this has to be differentiated from EHPVO, although semantically speaking, this is also extrahepatic portal vein obstruction, but this should be called portal vein thrombosis. The other thing you have to remember is that in cirrhosis, there is portal hypertension, but most of the collateralization occurs at the periphery, at the GE junction, at the splenic hilum, in the retroperitoneum. And you don't have that many collaterals in the HDL or around the gallbladder as you would see in EHPVO. So this has importance when you are planning to do a cholecystectomy in a patient with portal hypertension. It is relatively easier, not easy, relatively easier in a patient with cirrhosis, but very, very difficult or very, very dangerous in a patient with EHPVO, where there is a bunch of collaterals in the HDL and around the gallbladder. So you, at your level, at MCH level, you have to be able to differentiate between these subtle differences in various entities. Yes, Rajan, please proceed from wherever you left the discussion.
Yeah. So, what are the other stricturing causes of jaundice? Strictures of the biliary tree entirely. What are all the causes?
Sir, we can divide into benign and malignant causes. And then the benign causes, either it is stone related, it can be divided.
No, I said strictures. So, talk only about strictures. You don't classify them.
Sir, parasitic causes can be there. Parasitic.
Start with common causes, no?
Stones, sir. Most commonly, it is stone related.
Second
is chronic pancreatitis.
Yeah. What is typical of a stricture of chronic pancreatitis? When will you call it a stricture? And when will you differentiate it from a non-stricturous condition, which on imaging looks like a stricture? What is the difference between clinical stricturing?
Sir, in chronic pancreatitis, it will be a smooth.
When is surgery indicated? That's what I'm trying to ask.
Sir?
When is surgery indicated for jaundice caused by intrapancreatic obstruction of the biliary tree? How will you differentiate that from a benign stenosis?
So indirectly, what Dr. Desai is asking, that in chronic pancreatitis, if you have jaundice or evidence of biliary obstruction, does it always mean a stricture, or can it be due to something else? What are the causes of jaundice in chronic pancreatitis?
Sir, it can be a malignancy also. Malignancy is also is also a differential diagnosis. In kind of chronic pancreatitis patients, we have to keep.
So jaundice in chronic pancreatitis can be, one, because of a superimposed episode of acute on chronic pancreatitis. Just as you have some transient biliary obstruction in acute pancreatitis, so a patient with chronic pancreatitis can also have an episode of acute pancreatitis, and the inflammatory edema in the pancreatic head causing biliary obstruction, which is transient. As the acute pancreatitis settles, everything comes back to where it was. Second, you could have a cyst in or around the head of the pancreas, which is causing biliary obstruction. Third, you could have, as you rightly said, a superimposed malignancy. So that is why in a patient with chronic pancreatitis, recent onset of jaundice, which is progressive, raises or is one of the suspicious indicators of a superimposed malignancy. If the chronic pancreatitis is alcoholic, you could have alcoholic hepatitis, which is causing jaundice, but that would be medical jaundice, not obstructive jaundice. So, and finally, you have a stricture. So the characteristic radiological picture which Dr. Desai was asking you is a long, smooth stricture in the intrapancreatic part of the bile duct. And this differentiation is important because when you are operating on a patient with chronic pancreatitis who also has features of biliary obstruction, the recommended procedure is that first you do coring, phrase procedure. Now, in some patients, coring itself will relieve the biliary obstruction. But how do you document that? For that, you have to have a pre-coring intraoperative cholangiogram through the cystic duct. And then you do the coring and then you repeat the cholangiogram and see whether the narrowing in the intrapancreatic part of the CBD has opened or not. If it has opened, nothing else more is required. If it has, sometimes what happens while you are pouring, inadvertently, you get into the intrapancreatic part of the CBD. So now the CBD is opening into the poured head of the pancreas. You see bile. That also is all right, because ultimately you are going to put a loop of jejunum there. So it becomes an indirect choledocho-pancreato-jejunostomy. But after coring, if the biliary obstruction persists on intraoperative cholangiogram, or if the CBD is hugely dilated, some people will electively do it. You do a choledocho or hepatico jejunal anastomosis in the same loop of jejunum which you have used for the lateral pancreatico-jejunostomy. So that is the importance of knowing the pathophysiology of biliary obstruction in chronic pancreatitis.
Yes.
Yeah. So taking on from there, what are all the steps you will use to find out the diagnosis of cholangiocarcinoma of the biliary tree, extrahepatic biliary tree, or hilar cholangiocarcinoma? What are all the possibilities that you know of?
Sir, ERC and breast cytology,
What is the
cholangioscopy,
positivity rate of breast cytology in ERCP?
it's 10% to 20%, sir. It is low.
Around 20%. Is it specific or is it sensitive?
It's very specific, sir. Poor sensitivity, high specificity.
You mean to say if you get a few malignant cells, it's diagnostic of cholangiocarcinoma?
Sir, it doesn't diagnose cholangio, but it suggests some malignant pathology. It will not identify the.
It is a suggestion. So you have to go with that. Once you get this, you need to do more to get a biopsy, tissue biopsy. So what are all the techniques of getting a tissue biopsy? One is breast cytology. What else?
Sir, breast cytology, either ERC or PTBD, both ways we can.
Yeah,
Go
which is what Kapoor sir said. What else? Where
second, sir,
endoscopic
endoscopic
facilities are,
ultrasound, sir.
where
Endoscopic
you have
ultrasound.
endoscopic ultrasound. What about baby scope or cholangioscope, which is put through the ERCP channel? It's called a baby scope.
Yes, sir.
What is the baby?
Cholangioscopy is also. Sir, what is the?
What is a baby scope?
Sir, baby scope is a spyglass, which is a scope within a scope, which is usually done to identify visualize the hepatic ducts in the hepatic ducts and take a proper.
Not just intrahepatic, even the CBD that is there also, you can do a baby scopy through the papilla and you take a tissue biopsy. This is more reliable than doing a breast cytology.
Yes.
Yes. But not all units will have a spyglass scopy. So you should mention it lower down and as a specialized investigation. What else?
Sir, transhepatic biopsy is one more option where we can do by imaging guided biopsy.
Okay. So suppose you have a diagnosis of cholangiocarcinoma. What are all the investigations you need to get done to clarify?
Rajan, sorry. So one or two other things which do not have good yield. One is the bile cytology. You can just subject the bile to cytology. And other is that whatever tissue you get either on brush or on direct biopsy using a cholangioscope or a mother baby scope, you subject it to molecular techniques like fluorescent in situ hybridization, FISH. There are some reports where the yield has improved as compared to simple cytology or simple histopathology. Yes.
Yes.
Yeah, go on.
No, Rajan, you were asking something.
Yeah, once you're diagnosed or have a suspicion of cholangiocarcinoma of the extrahepatic biliary tree, I mean, you don't have intrahepatic, you have extrahepatic cholangiocarcinoma. What will all the investigations be that you will get done to plan your resection?
Sir, one is regular blood investigations and very specific investigations. Specific, I would like to know the liver function test and INR, LFT and total bilirubin and direct and INR I would like to know. And other than that, I would like to know whether the patient is having any cholangitis or not at that time, whether subclinical or clinical. That is another thing.
So what test you will do that?
Sir, I would like to see the total count, sir. If the patient is having fever and pain and fever, then we can have can say the patient is having a clinical features of cholangitis. But if it is subclinical, the patient will have just raised enzymes and raised total counts.
What else?
So I
What
think
are the blood investigations you want?
a better way to answer that question would be that I would do evaluation to one, assess whether the patient is fit for a major surgical procedure, and second, whether the disease itself is resectable or not. Isn't it? These are two different things. The disease may be resectable, but patient may be in a very poor general condition. The patient may be reasonably fit, but there may be contraindication for resection. So these are two sets of investigations. So tell us what all you would look for to see whether the patient is, because if it is a lower end cholangiocarcinoma, you may require a PD. If it is a higher cholangiocarcinoma, you may require a liver resection, both major procedures. So what all, you did mention something, what all evaluation you would do to see whether the patient is fit for a major procedure or not?
Cardiopulmonary evaluation of the patient and liver functions. Cardiopulmonary, it will be about the lung functions and the cardiac parameters. Specific for the patient, nutritional assessment of the patient and liver functions will be seen in the form of albumin. Along with that, I have mentioned liver functions, and very specifically, I would like to look for INR of the patient. And
Why do you want to look at the INR specifically?
Sir, INR suggests the liver function. The more INR is
Do you get that in a biliary obstruction?
Sir, yes, sir. We have always have to get an INR before planning for surgery.
Why do you get it? Why do you get it in biliary obstruction? Is that because of liver dysfunction?
Yes, sir.
Or something else?
Sir, parenchymal functionality, INR will be the test that is used to assess the on-spot.
We are talking of a cholangiocarcinoma. That is a biliary stricture. Bile salts won't enter the intestine.
What is the cause of deranged INR in a patient with biliary obstruction?
Parenchymal dysfunction, sir. Parenchymal dysfunction.
Is it?
No. What about malabsorption? You have forgotten malabsorption.
It is vitamin K.
Vitamin K.
Respondent, because there is no bile going into the bowel, so fat soluble vitamins don't get absorbed. It is vitamin K deficiency, and that is how you differentiate. In a patient who has deranged coagulation profile, you give vitamin K for 3 to 5 days. If the INR doesn't improve, you start suspecting whether there is parenchymal dysfunction, which can be there, as Sudeep has pointed out. If there is long-standing biliary obstruction, which is usually seen with benign biliary obstruction, that secondary biliary cirrhosis has developed. If the deranged coagulation profile is only because of biliary obstruction, it should respond to vitamin K. It should come back to normal. If it doesn't, you start suspecting secondary or primary parenchymal dysfunction, where then you need to correct it with fresh frozen plasma. So that is the basic difference between biliary obstruction and parenchymal derangement of patient profile.
Yes.
And you didn't mention renal function. You should have mentioned renal functions also. These patients may have renal dysfunction, which you need to correct or optimize before you take the patient for a major procedure. So it's sepsis status, which is cholangitis, nutritional status, liver functional status, especially coagulation profile, renal functional status, and then obviously cardiopulmonary evaluation. So that is as far as the patient is concerned. Now come to the disease.
Now, what about the situation of when you have a raised creatinine and a raised urea? How does it contribute to bilirubin? In what way? Bilirubin will fall, bilirubin will rise. What exactly happens to bilirubin if the renal functions are deranged?
Sir, increased bilirubin is known to cause decreased renal functions because of deposition of bilirubin in the renal tubular cells.
Bilirubin or something else? Is it bile salts or bilirubin?
Bile salts, sir. Sorry, bile salts. Bile salts deposition.
Yeah, but if you have renal dysfunction, will the bilirubin go up? It goes up because excretion of bilirubin is by conjugation. You get stercobilin and urobilin. The urobilin component reduces, therefore bilirubin rises, and stercobilin values also increase.
So this
Hello?
again is a
Yes,
very
sir.
favorite theory question. Renal dysfunction in obstructive jaundice. I think all of you should read. And there will be some keywords which some of them Dr. Desai mentioned, which have to appear in your answer. And the best way to answer a theory question is that you should mention as many as possible as you remember the keywords related to that, underline them, highlight them, so that the examiner's attention is drawn to those terms and he or she knows that, yes, you know what is the basic explanation for this. Okay.
So, how
Come
do you
to the
prepare the
disease.
kidney in obstructive jaundice?
How to?
How do you prepare a patient from the kidney point of view in a case of surgical jaundice? And how do you make sure that intraoperatively and preoperatively the patient's renal function is being taken care of? Will you operate on the first day the moment the patient comes?
No, sir. We should not operate. First of all, if the patient is having any renal dysfunction in a case of obstructive jaundice, the first and foremost is hydrate the patient.
Okay.
Hydration itself sometimes will improve the renal functions in these patients. Even if after hydration, adequate hydration, the patient's renal functions are not improving, that is an indication for stenting or drainage, external drainage of the jaundice patient.
What is the difference between external drainage and internal drainage? Any advantages,
Yes,
disadvantages of either?
internal drainage has two advantages over external drainage. The first thing is the maintenance of intrahepatic circulation, and so the patient will have a better electrolyte maintenance, and the nutritional maintenance will be better in this patient. Second is cholangitis will be lesser in ERC than PTBD, sir.
Less in ERCP,
Yes, sir.
cholangitis.
Yes, sir. It is
Are you
less in
sure?
ERC. Yes, sir.
You mean internal stenting, infections are lower?
Yes, sir.
Yeah, that's
PTBD
correct.
is, yes, sir. PTBD is
Why?
more
Why?
because of the
What is the function of biliary secretion on the gut? What all goes wrong?
aware of that, sir. I'm not sure.
The enterocyte function is deranged and the gut mucosal immunity is reduced when there is no bilirubin in the bile salts in the gut. That's why people start ursodeoxycholate tablets in patients with obstructive jaundice. Previously, we used to do a disgusting thing called bile refeeding, which is a most disgusting way of asking the patient to take bile. So most often we put them on orthodeoxycholic acid because most people cannot do biliary refeeding. So this increases the gap junction and it reduces the gap junction, and intercellular adhesion is also improved if you have bile salt in the gut. The second, enterohepatic circulation of bile also reduces uh, uh, what you call septicemia by reducing the amount of bacterial translocation in the gut. So these are the 3 or 4 mechanisms by which bile salts and internal drainage helps. How long will you wait after a PTBD for a hilar cholangiocarcinoma to do surgery? How long do you want to wait?
2 weeks, sir.
So students, as Dr. Desai pointed out, in the pathophysiology of biliary obstruction, especially in relation to sepsis, renal dysfunction, it is bile salts which are more important rather than the bilirubin. And bile salts, and same holds true for pruritus also. The pathophysiology of pruritus, it is bile salts which are more important than the bilirubin. Yes. And Sudeep also has mentioned that you should mention and you should remember that you need to review your drug chart so that you don't add on to the renal insult by giving any nephrotoxic drugs, especially some antibiotics and analgesics. So, yes, Krishna, next question. How long do you wait after biliary drainage in a patient with cholangiocarcinoma?
2 weeks, sir. I mean, it depends upon the nutritional status of the person and the indication for drainage. Ideally, we should wait for at least 2 weeks before 1 to 2 weeks, sir. 1 to 2 weeks before taking up the surgery.
Is it
No, no. The
6
correct
weeks,
answer
4 to
would
6
be,
weeks?
yeah, the correct answer would be it depends on the indication of biliary drainage. So let me explain. If the indication is cholangitis, then once cholangitis is settled, most people would wait for about 10 to 14 days for the inflammatory vascularity, tissue edema, tissue friability to settle and then operate. If the indication was renal dysfunction, as you pointed out, that is one of the indications, then once the renal function returns to normal, you could operate because that was the indication. If the indication was bilirubin, for example, if it is a hilar cholangiocarcinoma, you anticipate a major liver resection. If you follow the Japanese philosophy, then bilirubin has to come down to normal, preferably less than 3. If the indication was, suppose you have to do a PD for a lower end cholangiocarcinoma, and if the indication was just bilirubin level, because some groups follow a cutoff, some say 10, 15, 20, 25, some say it doesn't matter, then it depends on when the bilirubin comes to your acceptable level, which most people would say anything less than 5. So the time interval depends upon the indication. But as far as liver resection is concerned, experimental studies have shown that the mitochondrial function of the liver to improve takes much longer than the clinical or biochemical parameters. But then obviously you don't want to wait that long. And if the indication was to bring the bilirubin down for, say, portal vein embolization, for neoadjuvant treatment, then obviously you do that first and then you do surgery. So there's no one answer to this time interval. You have to say it depends on what was the reason for doing the biliary drainage.
Yeah. So what do you take care of in PTBD when you choose to do a PTBD, which is the thing by German or by Japanese criteria? How do you manage biliary tree? What is the essence of doing the drainage of the biliary tree?
Sir, it
In
should
terms
be,
of Indian philosophy and Japanese philosophy, what is the Japanese philosophy for biliary drainage?
sir, the Japanese believe in internal drainage, sir. They would prefer for an even that they do a PTBD, they will place an
In a hilar cholangiocarcinoma, to obtain an endoscopic drainage of the biliary tree is very, very tough.
they do it in the
Biliary tree,
PTBD.
mid CBD cholangio and lower CBD cholangio, internal stenting is easier because the axis is straight. The axis of the cholangiocarcinoma involves the duct origins of many ducts, and the directions at which they go will not ensure that the entire biliary tree is drained. Especially if you're waiting for cholangitis to come down, you have to drain all the biliary tree effectively so as to reduce cholangitis remaining so, and the patient continuing to have bouts of cholangitis. So most people, including Pickelmeyer, believed that you should do a external drainage or an internal drainage, but the aim should be that the entire biliary tree is drained.
So again, the difference of philosophy, as Dr. Desai said, the Japanese philosophy is that before any major liver resection, and how do we define major liver resection? Anything more than 2 segments is a major liver resection. The bilirubin has to come down to normal, preferably less than 3. On the other hand, some Western groups, including MSKCC and European centers, they initially did not believe in this philosophy. They went ahead with major liver resection without biliary drainage, but they had much higher mortality. Now, a new concept is coming that if you are doing a left-sided resection, a left hepatectomy, then this philosophy that you need to bring the bilirubin down it does not apply in all cases, especially if your FLR is more than the required, that means more than 30 or 25%. So good FLR, left-sided resection, many centers are not doing biliary drainage. That is the philosophy. Second is what biliary drainage? As far as possible, internal. And although it is difficult in hilar cholangiocarcinoma, but most Japanese centers also now have gradually changed from PTBD or external drainage to internal drainage. And with the expertise, they are able to do that. Third is that whether you need to drain, suppose it is a hilar block. Now, whether you have to drain one side or both sides depends on what is the indication. If the indication is only to bring the bilirubin down, then one-sided drainage usually is good enough. If it doesn't bring the bilirubin down, then you have to do the other side drainage. On the other hand, if the indication is cholangitis, then invariably you will have to do a bilateral drainage, whether it is endoscopic or percutaneous. Students, sorry, today we have some problem with Zoom connection, so we have a limited time. I think we will have to close in next about a minute. So I think we have. So, Rajendra, anything concluding? Otherwise, maybe we will.
No, this is an ongoing topic discussion. We'll do it at some other point of time.
Yes. So, students, again, please send me a mail, vkkapoor.india@gmail.com. Write CC, cholangiocarcinoma in the subject of. Milton wants to know if it is safe to refeed bile immediately after drainage. No. If the bile is frankly turbid, if the patient was having clinical cholangitis, you know that this bile is going to be infected, then not. You start refeeding only when bile becomes grossly clear. That means it is golden yellow bile, not turbid. And some people would insist on a negative culture also. And when you start refeeding, obviously you start with small volume, see how the patient tolerates, because in addition to being very sour in taste, it can cause severe irritation of the GI tract. So you start with small volume, see how the patient tolerates, mix it with some sweet fluid like honey or whatever, ruh afza. And obviously, if there is a nasogastric or nasojejunal tube, that is better. Nasogastric also is not good because bile can cause severe gastritis. Best, of course, is if for whatever reason you have an FJ. There is a small group of people who, when they do a PTBD, what they do that they